now we have different AR pathway inhibitor. Darolutamide was recently approved. We have enzalutamide, apalutamide, abiraterone. In your practice, do you have any preference in terms of which one you tend to use for certain patient population? Is there like a go-to drug?
I have used all of them over a period of time, but the newer ones seem to have a little bit lesser side effects. In my experience, the darolutamide has a little bit less CNS side effect. Patients don't complain so much about the things I used to hear with enzalutamide in particular. So I've tried to go that direction, but my mind is not made up. Sometimes there's also an insurance issue. Yeah. Sometimes they force our hand and say, no, this is our preferred product. It's happened a few times, but that's my experience with it, yeah.
I think darolutamide has been the most, at least I personally favor it because of the same favorable side effect profile, as opposed to enzalutamide, even AbbVie. Where a lot of these elderly patients already have comorbidities and then they start having issues with more and more fatigue. So,
yeah, and between AbbVie and there's also the caveat of having to have a patient elderly on prednisone. I try to keep them at the 5. You don't get successful with the 5 all the time, so you have to get them at 10. Yeah. Then you're getting some diabetes that are already borderline and uncontrolled, or you're getting some issues long term because these patients are going to be on these first line ARPIs for at least on average 3 to 4 or 5 years. So even though it's close to physiological dosing, if you keep it at the 5, but if you go up to 10, it's going to take a toll on them with bone health, because bone health, I think, is somewhat underlooked at a lot of the data that's in prostate, and bone health is a very important component that we should always keep in mind, especially when we get to the castrate-resistant setting.
Yeah. Yeah, I remember when we actually did the Irison's trial, like 10 years ago, everybody's having a hard time to figure out who is on placebo, who is on darolutamide, because they all do well, in some.
Is there any CNS penetration with darolutamide? I mean, very little probably.
Yeah, so if you look at the molecular structure of this drug, is much bulky molecular compared to APA and enzalutamide. So the CNS penetration is much less. But there's also less drug-drug interaction because this is completely different drug.
We don't see the seizure risk talked about much with darolutamide. I've never heard or seen it. Obviously, enzalutamide, we always used to counsel patients on it. Yeah. So I think there's maybe another benefit there.
All right. So how about genomics? So when do you offer this test? Do you have a favorite test to order to this patient?
It's the flavor of the month. So I am doing germline testing for all my advanced prostate cancer patients now, because I have had, as we were talking earlier, a mixed response, but the PARP inhibitors have been a useful tool for a lot of these patients. Response is maybe 50%, but that's better than 0 that we had before. So I think I'd at least try to identify up front where are my BRCA, ATM, those BRCA-like mutations. On the liquid biopsy, that I wait till I'm more closer to hormone refractory and I don't have much options. Then I have one patient I was mentioning who I found MSI high prostate cancer, and he's responding very good to to ADT and to the immune immunotherapy, and well tolerated. Very aggressive prostate cancer response. 3 months, 4 months has been almost a complete response. PSA down from 58 down to 1 or 2, and all the meds, and he was very symptomatic. So that's another reason why I'm doing it. So germline for everybody, and then perhaps a liquid NGS on case-by-case basis. So which one to use? We are offering the liquid biopsy in-house for us now, but not all insurances. So we have to see what is the insurance preference. I've used almost all the major providers.
So do you use tissue as well? I know it may be from urological colleagues, you may have some access issues.
Yes, we have done. Prefer tissue
Right.
if I can, but if tissue is hard to, a lot of our patients are transplants. Somebody had prostate cancer surgery done 20 years ago,
Right.
15 years, very hard to track it down.
Yeah.
Those cases, liquid has been good. What is your experience with the concordance between liquid and tissue?
The concordance is good. But I like your strategy, when you have access to the tissue, you try to do it early on.
Right.
When they become castration resistant a few years later, the tissue may not be available because they only keep it for 10 years.
Right.
And then when they become castration resistant, the disease burden is also higher.
Right.
So you have higher ctDNA fraction, you have better yield to use the liquid biopsy. So I think this is a very good strategy.
Yeah, I think with more and more trials and more PARP being upfront, I think that's an excellent strategy. Start early germline somatic, and then when you're moving to more advanced disease, new higher volume disease, new clones, then cDNA if tissue is not available at that time point with the blood is just perfect to complement with any newer trials that are coming targeted as the patient is getting less and less available standard of care approved options.